This is week 5, organogenesis, skeletal, muscular, nervous systems, and limbs, part 1.
The learning objectives for this week are to explain the development of the skeletal system, including bones, cartilage, and joints, to describe the characteristics of osteogenesis imperfecta, to explain the development of skeletal, smooth, and cardiac muscles, to describe common types of muscular dystrophy, to explain the development of the nervous system, including the brain and spinal cord, and to explain the embryologic development of limbs. Also, to give examples of limb anomalies, citing the stage of maldevelopment. Please continue with the embryologic self-study at this link. Bone formation is of two types, endochondral ossification and intramembranous ossification. The majority of bones go through the process of endochondral ossification. In this case, you're using a cartilaginous template. Cartilage is flexible. Cartilage does not weigh as much as the bone does, and cartilage allows for growth in width as well as growth in length. Here on this picture, you can see the hyaline cartilage model, and you can see that when blood vessels are able to penetrate at the primary ossification center, the bone formation can start. It will move up towards the proximal epiphyses and down towards the distal epiphyses, the tips of the bone. This process is not complete when the baby is born, and in some cases will not be complete, depending upon the bone, until many years later. When a baby is born, the sutures, the seams that join the various bones in the skull have not fused together yet. And there are 6 fontanelles, 6 areas where they have not formed yet. And most people think you only have one fontanelle, and that's the large one in the front, which is the anterior fontanelle. But in actuality, you have the anterior fontanelle, 1, you have 1 posterior fontanelle, you have 2 sphenoidal fontanelles, and you have 2 mastoid fontanelles. They close at different times and will not complete their closure until about a year and a half after the baby is born. If we were to have them close too early, this could cause a condition called craniosynostosis, which I'm going to talk about in just a moment, which has many different complications. Craniosynostosis can be caused by mutations in many different genes. And there is also a connection between a mother taking valproic acid during early pregnancy. Smoking is associated, as well as thyroid disease, hyper and hypothyroidism. It is more common in boys. It's also associated with other skeletal defects. And how deformed the cranium becomes is going to be dependent upon which sutures are closed. Let's look at Crouzon syndrome. It's an autosomal dominant genetic disorder that is also known as the brachial arch syndrome. This syndrome affects the first brachial arch, which is the precursor of the maxilla and the mandible. The maxilla is the basic keystone bone in your face, and the mandible is your lower jaw. Since the brachial arches are important developmental features in a growing embryo, disturbances in their development create lasting and widespread effects. Crouzon syndrome is the most common type of syndromic craniosynostosis. It shares many of the same features as another syndrome called Apert syndrome, which I will discuss in a moment. This includes the abnormal development of the eye sockets, the prominent and widely spaced eyes, and the slow development of the midface. In patients with Crouzon syndrome, the forehead generally appears more rounded with a more normally shaped nose, and the eyes tend to be more prominent. Another key feature or difference is that patients with Crouzon syndrome do not have associated hand or feet anomalies as they do in other syndromes, including Apert syndrome. Crouzon syndrome presents many of the same associated issues as Apert syndrome, including airway compromise, sleep apnea, hydrocephalus, and eye exposure issues. It's important for patients with Crouzon syndrome to be treated by a multidisciplinary care team that specializes in caring for children with these complex disorders. Please go to this link at Children's Hospital of Philadelphia to learn about various craniosynostosis syndromes and including Crouzon syndrome. And I think it's important also to tell you that we do have a clinical affiliation with Children's Hospital of Philadelphia, and CARE is going to be going to that site in the spring. Another form of syndromic craniosynostosis is Apert syndrome, also called acrocephalosyndactyly. The closure of the fontanelles during prenatal development affects the shape of the head and face. Individuals typically have a flat, elongated forehead, and they also have prominent or bulging eyes due to shallow orbits. They also have recession or underdevelopment of the midface, referred to as maxillary hypoplasia, and they have syndactylia or fusion of the digits. The characteristic feature that distinguishes Apert syndrome from the other types of syndromic craniosynostosis is the presence of the hand anomalies, most commonly the syndactyly. These hand deformities can be quite severe and prevent the child from functioning normally. This is a picture of a baby that has Apert syndrome. You can see the high forehead, the shallow orbits in the face, and the malformed skull. In this slide, you can see the malformed hands and you can see the syndactylia. Patients with Apert syndrome may have associated intellectual or developmental disabilities. Specific cognitive deficits that may impact children with this disease include impairments in domains such as visual, spatial functioning, executive functioning, attention, memory, or general developmental delay. In addition, the Apert syndrome can be associated with hydrocephalus, sleep apnea, eye exposure issues when the eyelids can't close completely, and airway compromise that may require a tracheostomy. Apert syndrome is caused by a rare mutation of a single gene. This mutated gene is normally responsible for guiding bones to join together at the right time during development. Almost all cases are new mutations, and only about 1 in 65,000 babies is born with Apert syndrome. Treacher-Collins syndrome, which is also called mandibulofacial dysostosis, affects the bone development and other tissues in the head and face. The symptoms in people with Treacher-Collins vary. Some individuals are so mildly affected that they remain undiagnosed. Others have moderate to severe facial involvement and life-threatening airway compromise. Most of the features of the Treacher-Collins syndrome are symmetrical and are already recognizable at birth. In looking at the clinical findings of Treacher-Collins syndrome, some individuals are also born with cleft palate. In severe cases, the facial bones that are underdeveloped can restrict an infant's airway, causing respiratory problems that are life-threatening. Also, there can be obstruction of the small nasal passages. There is an absent or underdevelopment of the cheekbones or zygomatic bones, as well as the floor and side walls of the sockets of the eye. The mandible is often slanted and small, and the hairline is unusual, with the hair growing across the cheek like a sideburn. Some of the other clinical findings are the eyes are down slanting, there's few eyelashes, the lower eyelids are notched. They can have eye abnormalities that can lead to vision loss, which includes a coloboma. They can have large beak-looking noses. They can have defects in the middle ear that can lead to loss of hearing. And in some cases, they can have very small or missing thumbs. Treacher-Collins is caused by 3 genes on chromosome 5. TCOF1 and POLRID1D are inherited in an autosomal dominant manner. 60% of the autosomal dominant cases are due to a new mutation in the gene. The POLR1C gene is responsible for the disease to be inherited in an autosomal recessive manner. This is a family where the father has Treacher-Collins syndrome and the little girl also has Treacher-Collins syndrome, showing you the autosomal dominant inheritance of the disorder. I'd also like to tell you that if you'd like to see a movie on an individual who has Treacher-Collins syndrome, there is the movie that came out last year called Wonder. Another disease that is associated with the bones is the Klippel-Feil syndrome or brevicollis, where the individual has a short neck, a low hairline, restricted neck movements, fusion of one or more cervical motion segments, abnormalities of the brainstem and cerebellum, and they may have other birth defects including scoliosis and urinary tract infections.
The inheritance of KFS is caused by mutations in the GDF6 and GDF3 genes. It is inherited in an autosomal dominant manner. When KFS is caused by mutations in the MEOX1 gene, it is inherited in an autosomal recessive manner. Osteogenesis imperfecta, OI, is a disorder of connective tissues characterized by thin-walled, extremely fracture-prone bones that are deficient in osteoblasts, which, just remember about this, that these are the bone-forming cells. It is also characterized by malformed teeth, blue sclera, the white of the eye, normally white of the eye, and progressive deafness. The earliest known case is in a partially mummified infant skeleton from ancient Egypt, now housed in the British Museum in London. In 1835, Lobstein coined the term osteogenesis imperfecta, and he was one of the first to correctly understand the etiology of the condition. Other names for this disease are Lobstein disease, brittle bone disease, blue sclera syndrome, and fragile bone disease. This slide is showing you the difference between a normal bone and a bone that has osteogenesis imperfecta, which is a brittle bone. You can see the contents in the bone are basically shattered in the brittle bone, are not put together properly. This is a picture of a baby that has osteogenesis imperfecta. This is a picture showing what the blue sclera of this disease can look like. There are at least 8 recognized forms of osteogenesis imperfecta designated type 1 through type 8. All forms have brittle bones. The types can be distinguished by their signs and symptoms, although their characteristic features tend to overlap. Type 1 is the mildest form of the disease, type 2 the most severe. Other types of this condition have signs and symptoms that fall somewhere between these two extremes. Increasingly, genetic factors are used to define the different forms of OI. Mild forms of OI, including type 1, are characterized by bone fractures during childhood and adolescence that can often result from only minor trauma. Fractures occur less frequently in adulthood. People with these milder forms typically have a blue or gray tint to the sclera and may develop hearing loss in adulthood. Affected individuals are usually of normal or near normal height. I have a younger sister, who had a mild form of OI. We spent so much time at the emergency room from her breakages that she had in her bones from just a minor fall. It was amazing to me always that she was such a great athlete. She was a great runner. And as she got into adulthood, it is true that the fractures occurred less frequently. In the severe forms of OI, there's a lot of bone fractures that may begin before birth and result from little or no trauma. Additional features: Can include the blue sclera, the short stature, the hearing loss, respiratory problems, and a disorder of tooth development called dentinogenesis imperfecta. The most severe forms of OI, particularly type 2, can include an abnormally small, fragile rib cage and underdeveloped lungs. Infants with these abnormalities have life-threatening problems with breathing and often die shortly after birth. In looking at the inheritance, most cases of OI have an autosomal dominant pattern of inheritance. Many people with type 1 or type 4 osteogenesis imperfecta inherit a mutation from a parent who has a disorder. Most infants with more severe forms will have no history of the condition in their family. In these infants, the condition is caused by new mutations in the COL1A1 or COL1A2 genes. When osteogenesis imperfecta is caused by mutations in the CRTAP or P3H1 genes, the condition also has an autosomal recessive pattern of inheritance. Marfan syndrome we've looked at before, just going over a few points about it. Autosomal dominant, about 1 in 5,000 people have Marfan syndrome, including men and women of all races and ethnic groups. It affects the body's connective tissue and also plays an important role in helping the body grow and develop properly. There's a defect in the ability to make the connective tissue protein fibrillin 1. What happens here is it results in an increase in a protein called transforming growth factor beta, or TGF beta, which causes problems in connective tissues throughout the body. This in turn creates the features and medical problems that we associate with Marfan syndrome. This is a mother and a son who have Marfan syndrome. 75% of individuals inherit the autosomal dominant disease. The other 25% have new mutations. The clinical findings of this disorder are that some people have a lot of Marfan features at birth or as young children, including serious conditions like aortic enlargement. Other people have fewer features when they're young and don't develop the aortic enlargement or other signs of Marfan syndrome until they are adults. Some features of Marfan syndrome, like those affecting the heart and blood vessels, bones, or joints, can get worse over time. This makes it very important for people with the disease and related disorders to receive accurate early diagnosis and treatment. Without it, they can be at risk for potentially life-threatening complications. The earlier some treatments are started, the better the outcomes are likely to be. The clinical findings for Marfan's is slightly different for everyone who has a disease. No one has every feature, and people have different combinations of features. But some of the features of Marfan's are easier to see than others, and these include long arms, legs, and fingers, tall and thin body type, curved spine, the chest sinks in or sticks out, flexible joints, flat feet, crowded teeth, stretch marks on the skin that are not related to weight gain or loss. The harder to detect signs of Marfan syndrome include heart problems, especially those related to the aorta, the large blood vessel that carries the blood away from the heart to the rest of the body. And other signs can include sudden lung collapse and eye problems, including severe nearsightedness, dislocated lens, detached retina, early glaucoma, and early cataracts. Special tests are often needed to detect these features. This is a slide of a boy showing his spider-like fingers, his long fingers, which is referred to as arachnodactylia. This is a little girl who was born with Marfan syndrome. This is an adult with Marfan syndrome standing next to a normal height person. Let's look at some congenital limb defects. The cause of many of these is unknown. Risk factors include genetic abnormalities, growth restriction, mechanical forces that affect the baby in the uterus during development, exposures by the mother to chemicals or viruses while pregnant, specific medications, and possible exposure to tobacco smoke. But more research is needed on this. The diagnosis of congenital limb defects is made at birth. The most common defects can be classified as follows: complete absence of the limb, failure of the portion of the limb to separate, commonly you see this in fingers or toes, duplication, commonly seen as extra fingers or toes, overgrowth, the limb is much larger than the normal limb, undergrowth, the limb is much smaller than the normal limb, and congenital constriction band syndrome. This happens because of the early rupture of the amnion and resulting in bands that may become entangled in the extremities of the fetus, causing immobilization and constrictions of the limbs, amputations, and other deformities. The treatment it's going to be dependent upon the physician, the parents, and what the specific congenital limb defect is, as well as the child's age, overall health and medical history, and the child's tolerance for specific medications, procedures, or therapies. The overall goal for treatment of congenital limb defects is to provide the child with a limb that has proper function and appearance. And the treatment goals are going to vary for each child. However, some of them are to promote normal development, discovering sense of independence, encouraging self-care, improving cosmetic appearance, and adaptation. There are no standardized treatment protocols for congenital limb defects. Treatment options may include prosthetics, artificial limbs, orthotics, splints, or braces, surgery, or rehabilitation, physical or occupational therapy. Some congenital limb defects, such as cleft hands, may be part of a syndrome that includes other symptoms. In these situations, some patients with cleft hands may also have a cleft lip, foot abnormalities, deafness, or congenital conditions affecting the heart and digestive systems. The incidence of congenital limb defects is going to differ, and some are more common than others. The constriction band syndrome occurs in 1 out of every 10,000 to 15,000 births. The extra fingers and toes, polydactyly, occur in about 1 out of every 1,000 births. Please go to this site at Boston Children's Hospital to meet Aiden. Please go to this site to look at amniotic bands or constriction bands. And please go to this last site on amniotic bands. I want to close this section by doing a case study on a very rare disease. John and Shirley are expecting again after 2 miscarriages. They were told that they should have prenatal testing, but not before the 9th week. Shirley's hesitant upon the testing due to her fear of losing a child, as well as her religious background. She's an extremely religious woman. Shirley has an ultrasound in the 16th week, and she considers ultrasound to be safe. She is informed by her physician that there is a vascular malformation in the caudal half of the fetus. Shirley is a little reluctant, but she then agrees to have an amniocentesis. After several weeks, the results are inconclusive, except that the baby is female. But the diagnosis for the vascular disease is unknown at this time. The parents will not know the extent of the malformation then until birth. Their options are that they can terminate the pregnancy or they wait until the baby's birth to determine their options for treatment. They choose to continue the pregnancy, but have serious doubts that they will be able to handle what's to come. At birth, they are told that their daughter Emily has Cernomelia syndrome, a rare disorder also called mermaid syndrome. Affected infants are born with partial or complete fusion of the legs with additional malformations that may also occur, including genital urinary abnormalities, gastrointestinal abnormalities, anomalies of the lumbar, sacral spine and pelvis, and absence in underdevelopment, agenesis of one or both kidneys. Emily's lower extremities are fused together and she only has a portion of a kidney. She had to have immediate surgery to prolong her life, even for a short period of time. Individuals that have this syndrome may have 1 foot, no feet, or both feet, which may be rotated externally. The tailbone is usually absent, and the sacrum is partially or completely absent as well. Additional conditions may occur with the cereromelia, including imperforate anus, spina bifida, and cardiac malformations. Cereromelia is often fatal during the newborn period. The exact cause of this disease is unknown. Most cases occur randomly for no apparent reason. Most are likely multifactorial. At 9 years old, Emily is able to have corrective surgery to separate her lower extremities. The surgery is long and potentially lethal. In fact, without the surgery, she will not be able to survive many more years. Emily is told of the risk, and she says that she doesn't want the surgery, since she knows that people are different, and that she just happens to have been born more different than most people. Emily's parents honored her request and abstained from the corrective lower extremity surgery. Emily died at 10 years 2 months due to renal and cardiac complications. She had lived well beyond the life expectancy of a young girl suffering from this disease, but she lived her life in a way that she chose to live it. This is a picture of a baby that is born with this syndrome.